inshallah. So let us all begin our conference today with Quran and Surah Al-Fatiha. Bismillahirrahmanirrahim. Alhamdulillah Rabbil Alamin. إياك نعبد وإياك نستعين اهدنا الصراط الذين أنعمت عليهم. Alhamdulillah Rabbil Alamin. Wassalatu wassalamu ala Rasulillah wa ala alihi wa ashabihi ajma'in. First of all, we would like to say our thank to Allah Subhanahu wa Ta'ala for this opportunity to this morning to have our conference first in the year of 2021. Today's conference is the Department of Internal Medicine's turn to present, and we have selected a topic that will be presented by Dr. Aminuddin, and our expert panel will be Dr. Muhammad Naimmuddin, as well as Dr. Siti Suzeana from Redod. And the topic today entitled Deadly Injection, a Case of Non-Thrombotic Pulmonary Embolism. Without further ado, I will invite Dr. Muhammad Aminuddin to present the case, inshallah. So,
Assalamualaikum and a very good morning. Today I will present a topic as mentioned. Sorry, I will let's share my slide first. Okay, Assalamualaikum and a very good morning. I am Dr. Aminuddin bin Hasnol Aidi from the medical department. So today I will present a case in our clinical pathological conference with the title of Deadly Injection, a case on non-thrombotic pulmonary embolism. Okay, so I would like to start this case, this presentation with a case that we encounter in our hospital in Susmek, which is Mrs. SN. This case was encountered in December 2018. So this is a Mrs. SN. She is a 34-year-old lady with no known medical illness. She presented with a 3 days history of hemoptysis, associated with a 2 weeks history of worsening shortness of breath, and also cough with whitish sputum. She also experienced intermittent fever in the last 1 week of presentation. Prior to this onset, she was well, and there was no medical illness. Okay, she denied any TB contact or any ill contact prior to presentation. She is a non-smoker, no history of travel, and she denied taking any supplements or any traditional medication. She denied high-risk behavior such as drug abuse or promiscuity. In regards to her social background, she is a divorcee, recently divorced by her husband upon presentation. She has no children, and she works in an executive firm. She has no significant family history, for example, like cardiovascular history or any pulmonary disease from the family history. So initially, actually, she was admitted to the KPJ medical ward with that presentation, and she was diagnosed as severe community-acquired pneumonia. She was treated with IV antibiotics for 1 week. However, her symptoms persisted and not getting better, and she was referred to the IIUM Medical Specialist Center to our respiratory physician for further assessment and management. The impression back then was severe community-acquired pneumonia. In view of not responding to antibiotics, we would like to rule out any lung abscess or any necrotizing pneumonia. So investigation, when the patient arrived in a specialist center, the blood investigation was in normal range. The full blood count, renal function, liver function test, and other electrolytes are in normal range. And the CRP was noted not elevated. The ECG just showed sinus tachycardia. However, there is no ischemic changes. We proceeded with further imaging of chest X-ray, CT thorax, and later bronchoscopy. This was her chest X-ray when she first arrived in specialist center. So from the chest X-ray, we can see there is an opacity, non-specific opacity, mainly located in the bilateral lower zone and also at the peripheral area. I cannot show you the chest X-ray that was done in KPJ due to confidentiality matters. However, according to our respiratory physician, it is quite similar to this chest X-ray. So this chest X-ray was reported as non-specific opacities at both lung bases. So after done this chest X-ray, we proceed with a CECT thorax. So for the CECT thorax, I would like to invite my colleague from radiology, Dr. Suzeana, to go through with us in the CT thorax findings.
Assalamualaikum warahmatullahi. Now I'm going to share the screen. Please stop sharing. Can I please get someone to stop screen sharing? I'm unable to share the screen to show you the images. Assalamualaikum. Can everyone hear me?
Yes. So loud and clear, so just proceed.
Yes, but can someone please? I mean, your environment is too noisy.
Assalamualaikum. Can anyone hear me?
Yes, doctor.
Saya rasa kena bawa naik.
Hidayah ada
Link dia mana?
Can secretariat mute other people, please?
Okay. Tanya doktor dah dengar tak?
You can proceed. Everyone can hear you. Make sure the environment is not noisy behind.
Anyone can hear me? I'm just so this is the CT thorax done in multiplanar view for this patient. Please just bring you the okay. Can you see the image? Can you hear me? Okay. So scrolling. This is the CT thorax. Sorry for the inconvenience. Okay, so this is in CT view. So as you can see, there is extensive ground glass opacity seen in peripheral region forming wedge-shaped opacity or density pointing towards the apex in this patient. So it's best to see in the sagittal view here, this screen here, so it's pointing towards the apex. So it's quite extensive, involving bilateral lungs, all the lung segments. There is also a component of reticular opacities within the ground glass region. However, no other abnormality, no lung nodule seen, no cavitating lesion, no high lung mass or lymphadenopathy evident in this study. There is also no pleural effusion or pneumothorax. The cardio-mediastinal control is normal, no cardiomegaly, no pericardial effusion. However, if I switch into the soft tissue window, you can start to see that the bilateral breast is actually quite edematous. It's not common to see this in common patient. So you can see that the whole breast is actually very, very stranding, fat stranding with multiple nodules seen within the breast itself. Okay, so otherwise there's no other abnormality seen. So features likely represent pneumonitis or peripheral infarction from possible microembolizations given the history of the patient. Okay.
Are you saying anything? Because we are not hearing anything.
Okay, so actually the previous images that I show you is actually the CTPA done a few days later for this patient. So now I'm showing to you the CT thorax, which was done a few days earlier. Sorry for the confusion. So this is the CT thorax done on the 17th of January. You can actually appreciate that the ground glass opacities seen before is actually much less in this study. So it's actually progressive a few days later. So similarly, ground glass opacities with wedge-shaped distribution pointing towards the hilum, as you can see in the sagittal view here. There's also reticular densities within the ground glass opacities or ground glass density. I see. No hilar nodes, no other cavitating lesion or anything like that. And similarly, the breast density is very dense and edematous, and multiple nodules, as you can see here, within the breast itself with stranding, nodules again in the right and left breast. So similarly, same features that I said just now represent pneumonitis, and also because of the peripheral distribution make comes from the pulmonary infarction from microembolization. So I might share you the previous CTPA. It doesn't actually show any embolization at the main pulmonary trunk and also the pulmonary right and left pulmonary arteries is actually quite clear without filling defects seen within. And let me just scroll. So this is the trunk family pulmonary trunk and the right and left pulmonary artery. So scrolling to the branches, distal branches, you can't actually see any filling defects. Okay. So showing you again the severity, which is markedly worsening in this patient a few days from the presentation. Okay. So everything else is quite similar to what I said previously. Let me just show you the chest X-ray, which was loaded to our system, which was unable to be shown before. So this is the chest X-ray for this patient. It's actually quite bad. As you can see, there is a peripheral airspace opacity seen with reticular pattern sparing the central perihilar region. So it's predominantly involving the bilateral lung field, the peripheral lung fields, and no pleural effusion can be seen, no mediastinal widening to suggest any lymphadenopathy. Otherwise, there's no other abnormality. Apart from the breast, it looks quite dense in this study, in this X-ray. However, we cannot comment further than that. Okay, so this is the chest findings for this patient. Thank you.
Okay, thank you very much, Dr. Suzeana, for sharing with us, going through with us the scan. I'll go back to our slides. So, as mentioned by Dr. Suzeana just now, we can see that from the CEC thorax, there's a wedge-shaped ground glass opacity distributed perilobular peripherally on bilateral of the lungs, and it was extensive. And also there was an incidental finding, as mentioned by Dr. Suzeana just now, that there is also an heterogeneous dense breast with extensive subcutaneous edema and multiple nodules, as shown in the arrows, as in the picture, with varying size on bilateral of both the breasts. So with these findings, we go back to the patient, explain to the patient regarding the findings, and get further history from the patient. At this point of time, our respiratory physician also consults the ONG, was thinking into the line of whether this is atypical presentation of a breast malignancy. We did ask further history from the patient regarding any family history of breast cancer, but the patient denied any family history of breast cancer. However, she confessed that she has undergone a breast fillers injection that was done 1 month prior to her presentation. She was actually undergone an injection of 300 mils of hyaluronic acid in each of her breasts. And she claims the procedure was done by a cosmetic doctor in Kemaman, and the reason for doing it is cosmetic reason. So with these new findings, we still proceed with bronchoscopy because we want to investigate why the first patient presented with hemoptysis, and we wanted to rule out anything else that in the lungs. So we proceeded with bronchoscopy in a specialist center, And this was the image of a bronchoscopy, which shown a normal vocal cord on the left side, and also on the right side, there's a carina is not widened. There is mildly inflamed airways. However, there is no endobronchial lesion seen. In the left upper lobe, however, there is a minimal bleeding. Adrenaline flush was given. Cytobrush was done. The impression at that point of time was hemoptysis was secondary to multiple pulmonary infarcts. So we revised our diagnosis from to rule out lung abscess or necrotizing pneumonia to non-thrombotic pulmonary embolism secondary to breast fillers, as suggested from the patient's history. So the progress of the patient, she was admitted in a specialist center. She was treated with IV antibiotics and IV hydrocod for 1 week. And we referred, our respiratory physician referred for opinion from plastic surgical team in view of the source of coming from the breast fillers. However, they were unable to remove the fillers in view of extensive diffusion in bilateral of the breast tissue. And the alternative option is for mastectomy. Obviously, the patient refused mastectomy. The definitive or diagnostic way of investigation is, of course, lung biopsy, but it was not done due to invasiveness, and the patient did not agree for any lung biopsy. So upon discharge of 1 week admission, patient hemoptysis has resolved when she was discharged from our specialist center. However, she still persisted to have exertional shortness of breath. Whenever she does activities with more activity, she will become breathless. So she has rented oxygen concentrator at home and used that intermittently. She also faced a financial issue as the insurance company declined the payment that she initially went to KPJ and also to our specialist center in view of the reason being cosmetic. She was then arranged for our clinic follow-up under our respiratory physician, and we wanted to do a follow-up HRCT with the patient. However, she defaulted due to financial reason. So this is a uncommon case that we have seen in coming in our hospital, and surprisingly, this is not the only case that has presented to us. This is, I would like to present a more latest presentation of a similar case. So this lady, she presented in year 2020, which is in March 2020. Mrs. MZ, she is 37 years old with underlying hypertension and the private GP follow-up with a medication of Twinstar. She presented with a shortness of breath, of a history of 4 days with pleuritic chest pain, and also a history of fever and cough in the last 2 days. She presented because she thinks the fever is not getting better. Upon further history taking, she claimed that the symptoms started the same day after she has taken IV vitamin C drip. This was not an injection, but this is a drip. She was inserted granular by a cosmetic nurse and was given IV vitamin C drip. She claimed it was for cosmetic purposes and for whitening of the skin. Previously, this is not the first time that she has undergone this vitamin C drip. It was she had it before, and she claimed that there was no complication with this cosmetic treatment. Apart from that, she denied any other ill contacts or denied any other symptoms apart from the acute onset of respiratory and fever symptoms. She is a non-smoker. She is married and has 4 children. Worked as a secondary school teacher. And last childbirth was 6 years ago, and at the point of time, she also done a bilateral tubal ligation after the delivery. She denied any high-risk behavior, no drug abuse or promiscuity. And upon arrival, this patient came to our SASMEC hospital in ED. So we can see that the patient is tachycardic, slightly tachypnic, however, SpO2 maintaining at 99% under room air. Her lungs on examination was clear, and there was no other significant findings of the heart and also abdomen. Blood investigation, again, same with the previous patient, showed normal range. full blood count, renal function, liver function test is all normal. ECG showed sinus tachycardia, however, there is no ischemic changes. At this point of time, we plan for chest X-ray and also CTPA in view of she has a sinus tachy and also pleuritic chest pain with shortness of breath. We're thinking along the line of pulmonary embolism. This was her chest X-ray. Again, if we can look at this chest X-ray, it's not as bad as our previous patient. However, we can see the distribution of the abnormalities is on the bilateral lower zone. There's a non-specific opacity in that region. So after that, we send the patient for urgent CTPA. At this point of time, before the CTPA, our impression in emergency department was we just cover for atypical pneumonia and to rule out pulmonary embolism. So again, I would like to invite my colleague from radiology, Dr. Suzeana, to go through with us the CTPA of this patient.
Okay, thank you, Dr. Aminuddin. Okay, now let me show you the screen. Okay, so this is the chest X-ray done for this patient. As Dr. Aminuddin said just now, the chest X-ray was not as bad as the previous patient's chest X-ray. So as you can see, there is bilaterally, quite symmetrically, per se, that there is a bilateral low zone, mid to low zone airspace opacities with reticular dense opacities as well seen in bilaterally. It is sparing the upper lobes, upper zones in this patient, and there is also there is no lymphadenopathy seen in this patient as well. There's no pleural effusion, and basically that's it. There's no other cavitating lesion, no nodules that we can see, no hilar mass can be seen in this patient, and we can also appreciate that the bilateral breasts are quite dense and quite enlarged in this patient as well, and no pneumothorax seen in this patient. So we proceed with the CTPA for this patient, just done quite urgently. So this is CTPA done on the 20th of March. So in 3D multiplanar view, scrolling the main pulmonary trunk, the right and left, there is no filling defect seen within the main pulmonary trunk and the branches, and also the segmental branches. We are unable to see any embolic materials or filling defects within those arteries. However, the chest findings are quite interesting. So as you can see that this CTPA was quite different from the previous patient. However, it's a bit similar as you can see that the distribution is quite peripheral. There's also a component of wedge shape density seen bilaterally. For this patient, the ground glass densities and also the reticular pattern. And for this patient, the upper zone is not it's not involved, apart from a few ground glass opacity densities can be seen in the anterior part of the bilateral upper zone, upper lobes. And no other cavitating lesion or nodules can be seen in this patient. No hilar mass, no pleural effusion, no pneumothorax. And similarly, from previous patient, you can appreciate that the bilateral breasts are very edematous with multiple nodular densities. Okay, here as you can see. Okay, so our conclusion was no evidence of pulmonary embolism. However, the wedge-shaped peripheral air space and ground glass opacities densities may represent pulmonary hemorrhages with component of pulmonary infarction. Okay. Okay, I'll let Dr. Aminuddin continue first before I show the next images, which is the HRCP, which was done further down the line.
Thank you, Dr. Suzeana. So I would like to proceed with the presentation again. Okay, so this was the CTPA that was done, that was explained by Dr. Suzeana just now. Sorry, I would like to have a break because of the prayer. So we will continue after the prayer. Semoga wahai yang Maha menyembuhkan, tidak ada yang dapat menyembuhkan, melainkan kesembuhan daripada itu kesembuhan yang tidak meninggalkan penyakit. Allahumma inna na'udzubika min jahdil bala wa daril syaqa wa su'il qada wa syama'atil a'da. Ya Allah, sesungguhnya kami berlindung kepadamu daripada yang berat, kesengsaraan yang berterusan, takdir yang buruk, dan kegembiraan pihakmu segala sepadanya yang menimpa. Bismillahirrahmanirrahim. Dengan nama Allah yang tidak memudaratkan, dengan namanya pada sesuatu pun di atas muka bumi dan di langit. Dan Dia Maha mendengar lagi Maha mengetahui. Allahumma inna na'udzubika min al-baras wal junun wal ghadab wa min sayyi'il asqam. Ya Allah, sesungguhnya kami berlindung daripada penyakit sopak, gila, kusta, dan daripada segala jenis penyakit yang menakutkan. Na'udzubika min al-tayyib wa min syarri ma khalaq. Kami berlindung dengan kalimat-kalimat Allah yang maha sempurna daripada segala kejahatan yang telah diciptakan. Rabbana atina fid dunya hasanah wa fil akhirati hasanah wa qina adzabannar. Sallallahu ala sayyidina Muhammad wa ala alihi wa sahbihi ajma'in. Walhamdulillahi rabbil alamin. Okay. So based on the findings as explained by Dr. Suzeana just now, we have noticed similar findings as per previous patient, which is a wedge-shaped ground glass opacity at the peripheral, distributed in the peripheral area, and also incidental findings again of the increase in density in bilateral both breast areas. So we go back to the patient, and this time we have experience. Our respiratory physician has previous experience in specialist center. So we confront the patient, and the patient admitted actually that she has had taken breast fillers injection, which is the similar hyaluronic acid as well, the same day that she took the IV vitamin C infusion. And in fact, she has been injected breast fillers annually in the last 3 years. So she has done that in March 2018, April 2019, and this time in March 2020. She was unsure when we asked her about the amount of fillers injected, but she estimated 100 mils per session. So, and the reason being similar to previous case is for cosmetic purposes. So in this case, the presentation is quite acute after the third injection period, where she immediately present with these symptoms. So our impression, we revised the impression again as non-thrombotic pulmonary embolism, similar to the previous presentation, secondary to breast fillers. And for this patient, we admitted to our hospital, SASMEC, and started her on IV hydrocortisone, 100 mg TDS, and started her on antibiotic, IV augmentin, and also cover for DVT prophylaxis, and also put her on oxygen as required. The patient was also referred to our surgical counterparts and also reviewed by them in the ward, and was given TCA under plastic team. Upon discharge, we tapered down the steroid to prednisolone, and also give the patient another 2 weeks of oral antibiotics, levofloxacin, and also give the patient calcium, calcitriol, and omeprazole due to the prolonged period of steroid. We advise the patient to rent or to get an oxygen concentrator at home based on our previous experience that the patient that was discharged still having exertional shortness of breath, and also arrange a follow-up under respiratory clinic, and also follow-up HRCT. In our medical clinic, upon assessment, there was no shortness of breath. She was comfortable under room air, not requiring any oxygen concentrator at home. She was complying to medication, taking it as per ordered. And also, however, she noticed there is an increased redness over the bilateral breast area. We proceeded with our plan for HRCT appointment, continued tapering down and to off prednisolone, and also we continue plastic team TCA. Upon plastic team TCA clinic review, they noted periareolar, circular skin erythema, warm and also indurated. However, there was not tender, and their impression at the point of time was allergic reaction to the breast fillers that she was taking. The management was at that time was conservative, and if worsening, for the patient to present herself to a hospital. So this was the follow-up HRCT that we did, and I would like to again invite my colleague from radiology to go through the image again to compare with the previous CPA that we have done.
Okay, thank you. Thank you, Dr. Aminuddin. So this is the HRCT of the patient done on the 7th of July. Okay, so as we scroll from the apex down, you can actually see that the previous ground glass opacities resolved already, apart from a few patchy ground glass opacities at the left basal areas here. Okay, otherwise marked improvement of the lung field, no nodules seen, similar from previously, there's no pleural effusion. So very marked improvement of the lung changes here. There's no ground glass opacities as we've seen before. Okay, so as we mentioned, there is also the breast changes remain the same. So it's actually quite limited still, and the skin is also quite thickened, as you can see here. Previously, it was not this thickened. The edematous area was quite the same. However, the skin thickness is worsening in this HRCT, and the nodular density still can be seen within both breasts. Okay, so that's all for my slide. Thank you.
Okay, thank you, Dr. Suzeana. I would like to share my screen again. Okay, so basically, this patient is different from our previous patient, where the HRCT follow-up showed marked improvement from all the wedge shape opacity that was noted before in CTPA, and the patient is currently comfortable in the room air, does not require any oxygen therapy. So this conclude the case presentation for today, and I would like to go into the discussion bit of this presentation. So when we speak about procedure or cosmetic or aesthetic procedure, we might think it's quite rare, or we would not encounter in our daily practice, especially in hospital. But however, if we look at the statistic, it's shown that it is actually not as rare as what we thought. It is quite common, and also patient is now moving up. The one who seek for these procedures are now moving from surgical procedure to non-surgical procedure. And as you can see from this picture that I've got from the internet, that the non-surgical procedure that has been done worldwide, hyaluronic acid, as in both of our patient, is the number 2, apart from number 1, botulinum toxin, as the non-surgical procedure for the aesthetic procedure. Okay, and all this procedure is not without complication, and also they are also used, apart from breast augmentation, they also used commonly in facial recontouring, or any lip or nose injection, or even vaginal rejuvenation. This is a case report of showing how this seem harmless injection can cause a severe complication. This is a case report from China, showing that this patient has had augmentation of the nose and nasolabial folds, a series of compilation of patients, and 30% has complication of nasal skin necrosis. So initially, the patient just want to undergo this procedure to get a purpose of beauty purpose. However, end up with getting worsened deformities, worse than previously. So another case report, this one is also reported in China. This was a case of a cosmetic vaginal tightening procedure, also with hyaluronic acid, which ended up the patient dying. And this is what it was done post-mortem, and they can see that there is a hyaluronic acid noted in the lungs of the patient that is the main reason why the patient passed away. And when we speak about non-thrombotic pulmonary embolism, it is definitely less common than its counterpart, which is a thrombotic pulmonary embolism. And also it can be due to multiple causes of any material that goes into the pulmonary circulation. Okay, it can also have paradoxical, where it goes to the brain. But in our case, the cases that I presented, it goes to the lungs and damage the parenchyma. And specifically for our case, it is the foreign material that caused the damage to the lungs. Okay. Before I go to the next slide, in regards to treatment, specific treatment for this foreign material, there is not much study shown or any guideline to show what is the exact treatment of hyaluronic acid. So the studies were still scarce, and also the only foreign material that is being studied at the moment in terms of treatment is silicone, because there's a lot of, as mentioned before, there's a lot of procedure involve breast augmentation, especially the surgical procedure involving silicone, and the treatment is steroid. Usually, they would also cover with antibiotics, because when patient presented, it's always a delayed presentation, and it's always complicated by a concomitant chest infection. That is the only reason why the patient is also covered with antibiotics. There is no specific evidence how antibiotics would work in this sort of presentation. So in regards to Islamic perspective, I think this is another lecture by itself. But I'll try to summarize this Islamic perspective based on the journal of British Islamic Medical Journal in April 2020. So basically, in summary of this reconstructive plastic surgery, Islam permits plastic surgery if the purpose is for treating the disease or to save and preserve the function of the body of the body organs. For example, if the patient has had an accident or is born with a cleft, palate cleft, and is allowed to have all this plastic surgery. It is not permissible to undergo all this cosmetic surgery when the purpose is to merely to beautify oneself or to follow the latest trend, because this has gone against hadith that mention we cannot alter the creation of God without a valid reason. So the take-home message for today is that cosmetic procedure that seems to be harmless can also be harmful and even be dangerous to the life, fatal and deadly. And we as a medical practitioner has to be more cautious if the patient presents with atypical presentation, and always go back to the patient and ask if there is any further history that we might miss. With that, I would like to pass the presentation back to Dr. Ismail for our expert review from if Dr. Naim wants to add anything.
Okay, thank you very much, Dr. Amin. So I'll pass the session to Dr. Naim if there is anything to add that we can learn from this case. Is Dr. Naim around?
Yes.
Okay. Yeah.
Actually, for this sort of presentation, we are thinking about how breasts are related to the lungs. So these two cases illustrate how interesting this human physiology can be. So the mechanism of how we actually getting this embolism to the lungs from the breast for these two patients is actually extravasation of the particulate that be injected to the breast. But however, just to add another few points from Dr. Amin just now, in these two patients, apart from follow-up HRCT, that we want to do basically to assess the residual damage to the lung caused by extensive microembolism to the lung that causing pulmonary fibrosis, is actually to do lung function test. However, we have problem with our lung function machine on that particular time, so we are unable to do for these two patients. So apart from HRCT, we should do lung function test to assess the severity of the lung damage caused by non-thrombotic pulmonary embolism by these two patients. So again, high index of suspicion is very important when we want to suspect this rare presentation of lung condition. With that, I pass back to our chairperson, Dr. Ismail. Thank you.
Thank you, Dr. Naim. Anything to add, Dr. Suzeana? From a radiological perspective?
No.
No, nothing. Okay, that's fine. So shall we open for
Hello,
the
Ismail.
floor?
Assalamualaikum.
Okay, go ahead. Yeah.
Hi, Ismail. Assalamualaikum.
Yeah, go ahead.
Hello. Yep. My name is Aidi here from radiology.
Okay. Okay. Good.
The non-thrombotic pulmonary embolism is not a common thing, as we've probably discussed today. I think it's fair to not label anyone an expert in this method alone myself, but compared to its counterpart, the blind thromboembolic pulmonary embolism, it's not a simple matter of mechanical obstruction of the pulmonary artery, so whereby we can actually see the filling defect within the opacified pulmonary artery branches. So in our cases, so these two cases, hyaluronic acid, I think, is considered particle embolisms. So these microparticles actually lodges within the small pulmonary vessels at the periphery, which cannot be seen on your box standard CT pulmonary embolism, i.e. it's not a simple mechanical obstruction. So instead, you get these microparticles triggering focal inflammatory response at where the microparticles lodges. So I think Dr. Naim can probably correct me if I'm wrong. So you get macrophages, etc., and friends going to this region. And I think this is reflected quite beautifully in the CTs that Dr. Suzy has kindly shown us. So you get peripheral, fluffy ground glass changes, okay, which is typically seen when you get exudates going into the air spaces. In fact, if these findings were reversed, i.e., the ground glass opacities seen at the central part of the lung, not the peripheral part, as in our case, you can comfortably call it a back wings edema in your congestive heart failure. However, these findings are by no means exclusive to non-thrombotic pulmonary embolism. So you don't see it in all your NTPs. You can get it in severe pneumonia, for example. So, but in this day and age, I think you'll not be wrong to call this CT images as COVID. So I think the old adage still goes, how do you say? Treat the patient and not the scan. I think that's all from my side. That's Ismail. Thank you.
Thank you, Aidi, for your input. So shall we open for questions from the floor?
Yes, actually, when we talk about inflammation in the lung, that's why in these two patients, we started them on anti-inflammatory, that to say intravenous hydrocortisone, and thank God they were working for these two patients. So, but there's no hard and fast rule how we which steroid to use, how to taper it off. But then the use of corticosteroid might help in certain patients. So we might consider adding this corticosteroid therapy on top of covering for superimposed bacterial pneumonia with antibiotics. Okay, thank you.
Okay, if there is no more points to share from our expert panel, from our physician as well as our radiologist, we'll open the floor for any question from the audience. Before we start off with the question that we have on the chat window, a question from Hazrul Hazwan to say whether mastectomy will improve the patient's symptoms. I mean, could you respond to that, or any of our expert panel?
Yes. Correct me if I'm wrong, because there's a lot of I think plastic surgeon team also as well in the audience, and also Dr. Naim. But I think the idea of mastectomy is to remove the source of the disease itself, because as Dr. Naim mentioned just now, it extravasates from the source, from the hyaluronic acid in the breast area into the circulation and ended up in the lung. If we did not remove the source, there is always a possibility in the future that it will occur again. It will extravasate again and end up in the lungs again. Yeah. That's the reason why we would like to remove the source of the condition, the disease. Correct me if I'm wrong, Dr. Naim.
Yeah, I think you are right. But then from my reading, when I'm reporting these cases for publication, there's no papers that shows how we should treat the breast fillers in patients who develop non-thrombotic pulmonary embolism due to these particulate matters. And maybe we can ask our plastic surgeon team, maybe they have experience with this condition where they have to remove breast fillers or implants when they have complication. Local complication, I read a lot when they have infected silicone implant, for example, but the systemic complication of this breast augmentation procedures due to particulate matters, there are none actually being shown in the English journal. So I hope that our plastic team can actually give some comment or some expert opinion on it as well.
Is there any plastic in the crowd to respond?
Can I just
If there, sorry, go ahead.
Okay, based on my personal communication with plastic surgeon, they are not very keen to remove free breast fillers. It is different from silicone implants. So for free fillers, it is injected like everywhere in the breast, so it's almost impossible to remove the fillers.
Okay, so just to make sure that every single person who wants to talk, make sure you introduce yourself, because we are blind. We cannot see your face, or we cannot recognize you based on your voice. That's fine. Any other question from the crowd, from the audience?
Assalamualaikum warahmatullahi wabarakatuh. I would like to ask whether there is any role for anticoagulant, not for DVT prophylaxis, but for in terms of treatment for this particular non-thrombotic PE.
As we understood the pathophysiological mechanism of it, it is not due to thrombosis. So there is no role of anticoagulation in this sort of patient. And in first patient as well, if you remember, she has hemoptysis. So anticoagulation might be harmful in this patient. So for non-thrombotic pulmonary embolism, there is no role of anticoagulation.
Any more questions? So there is 3 more minutes to 9. If there is no more question from the audience, I'll probably wrap this up for this session. Thank you very much for the presentation, Dr. Amin, as well as Dr. Suzeana, for sharing your input to share this interesting case as well.
Sorry, Ismail, because I read the chat just now. Did you saw one question?
Okay, sorry.
The question is, as primary care, does lateral view chest X-ray is helpful in this kind of case? I think best answered by the radiologist, but clinically it does not. Lateral chest X-ray will not give any further information. So this patient should be referred quickly to tertiary center for CTPA in order to assess for the all the findings that we discussed just now. So I think don't bother to do lateral chest X-ray. Just refer the patient, and then we will arrange CT scan for the patient.
Any input from radiology?
I agree, Ismail. Thank you.
Thank you very much. Let me check the chat box again. There's no more question. So, okay, thank you very much for all. Thank you again, Dr. Naim, Dr. Aidi, Dr. Suzeana, Dr. Amin for the presentation. Hopefully we can learn from this, and just be mindful that our generation now is very much different than the previous textbook. Probably not mention all these cases. In my experience myself, breast implant lymphoma is quite common, but not with fillers lah. But again, all of them normally will require removal of the implant or the breast filler to prevent further induction of any lymphoma. Thank you very much. So hopefully we can learn from this. We end our session with Tasbih Kafarah and Surah Al-Asr. Subhanakallahumma wa bihamdika asyhadu an la ilaha illa anta astaghfiruka wa atubu ilaik. Wal 'asri innal insana lafi khusr. Assalamualaikum warahmatullahi wabarakatuh.